Planning ahead is essential. Understanding likely demand helps allocate resources effectively. Here at the TU, we've developed a model for West Midlands Cancer Alliance to do exactly that.
Hi, I'm Elliot from the NHS Transformation Unit. We're a team of transformation professionals working alongside health and care clients to deliver major change programmes. In this episode, we're going to talk about the importance of screening, in particular, the rollout of lung health checks and how organisations can plan their services to meet any increased future demand. But first, let's start with an explainer.
When we think about lung cancer, the conversation often centres around treatment or smoking cessation. But what if we looked somewhere in between? What if we targeted early detection? That's exactly what the NHS is aiming to do through its targeted lung health check programme. The goal is simple but powerful. Find lung cancer earlier, giving patients a better chance of survival. And the numbers back it up. Almost 65% of people with stage 1 survive for more than 5 years after diagnosis. For people with stage 4, it's only 5%. Early detection isn't just important, it's life-saving. By 2029, the plan is to invite everyone with a history of smoking to a lung health check. It's a proactive move that could transform how we detect and treat lung cancer. But it won't be without its challenges. Increased screening will result in a sharp rise in the demand for diagnostic and treatment services. And this is where smart planning, informed by local population health needs, can help.
With me today is Sarah Maynard. Thanks for joining us, Sarah. Would you mind giving us a brief introduction to your background at the TU?
Thanks, Elliot, and thanks for inviting me here today. So I am an Associate Director at the Transformation Unit, and I've been here since 2017. And from the start of working with the Transformation Unit, I've been very heavily involved in cancer improvement projects. So my work has ranged from doing pathway and process reviews right through to quite significant system service redesigns and implementation programmes.
Brilliant, thank you. And so we're talking today about lung cancer. Why is that such a key focus for the NHS right now?
Yeah, so sadly, lung cancer is the leading cause of deaths by cancer in the UK, and it's often diagnosed late. So over 50% of cases are diagnosed at either stage 3 or 4, which is the latter stage diagnosis for cancer. Those individuals who live in more deprived communities are also at the greatest risk of having lung cancer or actually developing and dying from lung cancer. So by tackling it, it allows us to address health inequalities and also tackle early diagnosis targets.
So what are the major risk factors and how do they intersect with those health inequalities?
So unsurprisingly, smoking is the biggest risk factor, and 85% of cases are linked to smoking. And air pollution, exposure to occupational hazards like asbestos, and family history are also big factors. Those living in deprived communities have a higher likelihood of smoking and also a lower uptake of screening. And there still remains quite a bit of stigma around screening, which can affect early detection.
Okay. And so what difference does early detection make then?
It makes a massive difference because if it's caught early at stage 1, it really does increase your 5-year survival rate. And if you detect it later, so at stage 4, it really reduces that survival rate to less than 5%. Early detection also allows for a much broader range of treatment options, including curative surgery. And in doing that, you're going to take some pressure off the NHS longer term. So it's a massively important step to take.
Okay, brilliant. So we've talked there about taking pressure off the NHS, the importance of detecting early. So how does that fit in with the targeted lung health check programme?
So the targeted lung health check programme is CT screening in the community, and it's targeting those at greatest risk, so those aged between 55 and 74 with a history of smoking. The screening takes place in more accessible locations, so often in supermarket car parks, for example, And by undertaking that early detection programme, it can also identify not just cancer, but other diseases like COPD.
So, lastly, why is increasing screening important, and how can healthcare systems prepare for the impact?
So expanding screening programmes is really important because obviously detecting cancer earlier at the earliest point is really the best thing for patient outcomes. But in doing that, obviously it's going to increase demand on the system upstream. And so we need to plan and prepare for that. And we've actually taken steps in the TU to build a model, particularly for West Midlands Cancer Alliance, to help predict that demand so they can target and allocate resources appropriately in support of that anticipated increase in demand. Whilst that's been developed for West Midlands Cancer Alliance, we can support any system and make that a bespoke tool for those systems' need in particular.
Thanks for joining us today, Sarah. That's been a really interesting and probably quite timely conversation. As Sarah alluded to, the TU works closely with West Midlands Cancer Alliance to develop a model to forecast demand for screening, appointments and procedures. Next, I'll be joined by Andy Wilson, the TU's modelling and analytics lead, to tell us more. Hi Andy, thanks for joining us. Would you mind telling us a little bit about your background, please?
So I'm Andy Wilson. I'm the modelling and analytics lead at the transformation unit. So my background is I've worked in the NHS for many, many years now, worked in lots of roles across acute commissioning and other on-site bodies. Those have all been analytical roles. So a lot of what I do involves obviously analysis and modelling, particularly kind of focus on things like demand and capacity modelling, looking at what changes to services, how that could impact in terms of the demand for those services, what capacity we would need to meet them. So that's kind of typically what I've done.
So what is the purpose of the model?
So simply put, the model's purpose is to forecast the expected activity and demand that you'd expect to see from the lung health check pathway. So as we obviously look for new people, we invite people in and they attend, there's going to be a knock-on effect. So the model's looking to predict how many scans do you think we'll do? How does that translate to cancers that are going to be diagnosed? And then additionally, what other investigations might those patients have? So things like PET scans, and then who might go on to have other treatments as well. So whether that's a surgical resection or radiotherapy, essentially.
Okay, so we know the purpose of the model, but what type of model was it and how was it built?
So the model is a discrete event simulation model. So what that does is it basically looks at the pathway, maps the pathway along kind of key events, and then we can basically apply some assumptions in those key events that explain how patients would move along the pathway. So how the model's built, we've built that in a system called RStudio that uses the R programming language. It's totally open source, which is really good. And we've used that to basically build the model, build all the steps on the pathway so that we can then put in all those assumptions about how patients flow and move from one stage to the next.
Perfect, thank you. So the model was built using discrete event simulation. What is discrete event simulation and what's the value in using it?
So discrete event simulation is a modeling technique and it's often used, it's used a lot within healthcare, but it's kind of used a lot to model systems or pathways where you can essentially break it down to a series of events or a sequence of events. So typically in say something like a healthcare setting, a patient might attend a clinic and then once they attend that clinic and they have that appointment, there's potentially different outcomes that patient could have. Yeah. So they could be discharged, they could be referred on to another clinician, they might be sent for a diagnostic test. And the way that we can think about it from a modelling point of view is that there's almost like a probability of each one of those things happening. So maybe there's a probability that 10% of the time they'll be discharged, 40% they'll go on for they'll be referred on to another specialty, for example. So we can build a model where at each of these events there's a series of probabilities. So these are essentially these discrete events where you have something along the pathway. At that point, there's a probability that then you will go down a different path. So you kind of almost flow each of these patients or these entities along that pathway based on those probabilities that you set. What it's really good for is that then it gives you an idea of, well, okay, based on those probabilities, what's the kind of expected outcome? So we'll see that in lots of runs of the model, you'll end up with a kind of like expected outcome. So this many patients will be discharged, this many will then be referred on. But it kind of gives you a range of outcomes because it's using those probabilities. So you get a sense of, yeah, this is what's expected, but here's a range of things that might reasonably happen. And then there's also, in the extreme cases, this is what could happen. So it gives you a way of kind of testing, do you have the capacity that can deal with those things as well?
Okay, perfect. Thank you. Sounds quite complicated. What kind of data does it use and what outputs are provided?
So in terms of the data that's used, we have an input sheet, so people can input the assumptions for the scenario they're interested in modeling. So the data that sits behind that could come from lots of local data collections, or it could come from the sort of best estimates of what people know about the health checks themselves. So obviously involve clinicians. The model takes up that spreadsheet, all those assumptions, maps them out to various parts of the pathway, and then runs that through the model. So then at each stage of the model, it uses that information to make a prediction about how those patients move from one stage to the next. In terms of the outputs of the model, obviously then we know how patients move. Yep. The model outputs then are kind of created into a nice report using something called our markdown, and that basically shows at each stage of the pathway how many CT scans do we think we expect to see, but also the probable range as well, because obviously with a lot of these things there's a bit of uncertainty, so that's why discrete event simulation is kind of a really helpful way of doing it. So we have those sort of ranges of what we might expect to see, so I suppose a likelihood. So we can kind of then see that, so for each stage of the pathway, so things like CT scans, things like the additional diagnostics I mentioned earlier, we have what would be the estimate for that scenario, how many additional tests do we think we'll see, how many additional chemotherapy treatments are we likely to have to implement alongside the range of those things.
How can people access and use this model?
So in terms of accessing and using the model, it's publicly available, totally free to use. The entire code base for recreating the model is available on our GitHub repository. So that is a repository that contains all the code for everything that we've used to build the model. Obviously, the only slight thing to remember is that we built this model for the West Midlands Cancer Alliance, so it's very specific to their pathway.
Yeah, of course.
So obviously it flows and the model flows using their pathway. Yeah. There is obviously diagrams of what that pathway looks like, so we can kind of explore that and see that, and that's also recorded within the repository, so it's all in that one place.
So what skills do people need to access and use the model?
So the model's publicly available on our GitHub website, so there's a repository there that has all the code that's used within the model. So anybody can go there and access it. Obviously, if you've got a bit of a background using things like Git, and particularly R as well, because that's what the model's built in, that's going to be more helpful for kind of understanding how the model's pieced together. Having said that though, within the kind of documentation for the model, there's really kind of clear instructions that go through, this is how you access the model, this is how you download the code, and this is how you use it. There's also some very straightforward instructions for the input spreadsheets. So that contains all the assumptions for each stage of the pathway. It's just a simple case of kind of opening that spreadsheet up, putting in your assumptions, saving that, and then rerunning the model with those new assumptions in there.
Okay.
Andy's now going to give us a demonstration of the model to both showcase how to use the tool and how readily available the insights it generates are.
A more detailed version of this demonstration can be found on our website, but I'm just going to give a very quick overview to help contextualize the conversation we've been having throughout this episode. So as we've discussed, the model is openly available via GitHub, which will look like this when you open it. It contains all the code, pathway diagrams, and example inputs ready for you to explore or adapt. The model was built using the lung cancer pathway developed by the West Midlands Cancer Alliance and follows patients from invitation through lung health checks and CT scans to diagnosis, treatment, and follow-up. The visual pathway helps map out every possible patient route as well as where to apply the assumptions. The assumptions found in this Excel spreadsheet include population characteristics, opt-in rates, DNA rates, and clinical outcomes, such as how many patients may need follow-up or specific treatments following their screening. There are dedicated tabs for each stage of the pathway, which makes it easier for the user to adjust to a particular scenario that they wish to model. The tool is built in R and can be run through a single script. This simulates patient journeys, applying the assumptions we input, and then creates a report showing the outcomes from the model. You can adjust the number of trials the model is set to run for. Let's say, if you were set the model to 100 runs, it would take the results of all of these 100 and summarize the expected activities at each stage of the pathway. Outputs are summarized in an interactive HTML report. This provides activity estimates, the median number of additional diagnostics we would expect, the range in possible outcomes, 10th percentile, lower quartile, upper quartile, 90th percentile, that can be used to inform capacity and service planning for each stage of the pathway. This is quite a complex model with lots of components, but there is full guidance provided in the more detailed demonstration on our website and in the GitHub repository. The Markdown file contains the detail on how the model can be adapted to reflect different pathways or local changes, and the README contains the structure of the repository and where all the information is saved. So that was a whistle-stop tour of the model, but obviously there was a lot more that went into its construction behind the scenes, and how we ensured it could be adapted for future use.
Could you talk us through the high-level process that went into building the model?
So one of the first things that we needed to do really was understand the pathway.
Yeah.
That was like the key point. So speaking with the client to make sure we had a good sense of this is how the pathway works in practice. So what are all the steps? How are patients referred in? What are all the kind of entry points for the model? And then map that pathway out with the various stages, with all the different routes that patients could take, and make sure that they were kind of clear in terms of this is what we're attempting to build within the model. We're going to replicate a version of this pathway within the model. So we spent a bit of time at the start in terms of kind of obviously sitting down with them, kind of mapping that all out, understanding what all those different steps were, and then understanding those kind of endpoints for the model. So once a patient's essentially been invited in, maybe they've been diagnosed and they've had some treatment, that's the kind of end of their pathway. But then there'll be other patients who are potentially followed up for, say, 2 years, for example. So they might come back in and re-interact with the pathway as well. So we wanted to make sure that we were really clear. This is the pathway. These are the starting points. These are the endpoints. This is everything that happens in between. So that was one of the key considerations. The other was obviously then thinking about how we want to go about building it. So we kind of then had to kind of chunk it down into the different stages of thinking about what tools and software do we use. So obviously we wanted something open source. So R was a really good contender for doing that. So I thought, right, we want to be able to produce the model in R. Obviously we used R Studio to kind of create it. And then also using software like Git to be able to kind of track the changes that we make to the model, because obviously we want to see how we've kind of developed the model over time. If we built some features into it and we want to perhaps go back or revert back to something, being able to do that, but also just having that history so we can see how the models change and develop over time.
So that's a key part of these models, isn't it? That they give us intelligence towards answering a question, but don't answer the question definitively in most cases. Thinking to the future now, how could we adapt the model in the future?
So in terms of adapting the model, it could be adapted to be used for a different kind of locality with a slightly different pathway. So you could obviously start to tweak the model to say, if you have a pathway where patients are perhaps invited at different points or they go down different routes, you kind of tweak and change the model that way. So you could still use it for something like a lung health checks modeling exercise, but obviously just change how that model reflects the pathway. But in terms of the kind of, I suppose, the techniques that are used within the model and how that's actually undertaken, it doesn't need to be used in cancer at all. It could be used for modeling kind of pathways across anywhere in healthcare, really. So whether that's anything from, say, like even just bowel screening, it could be used for kind of like urgent and emergency care at the front door as well. There's lots of different clinical pathways that could be used to model using these techniques. So it's not specific to cancer necessarily. There's lots of different clinical pathways where you could almost use these techniques to build a model similar to this that makes those predictions in terms of when you start to have patients entering a pathway, what are all the different routes that they could go down, how does that kind of change on the different assumptions, and then what's the knock-on effect of those things, and how does, I suppose importantly, how does that then translate to capacity? And do we have the capacity within the NHS to deliver those services? And that can also then act as a prompt to say, well, if the answer is no, and you have to kind of almost kind of work back and say, well, what set of assumptions would allow you to kind of fit that demand within the capacity you've got? That kind of gives you a bit of an indication of what are some of the challenges that you might need to do kind of almost further up the model to enable that to happen.
Okay, brilliant. Well, thanks for your time today, Andy. The model sounds really exciting.
Thank you.
We've heard about the importance of lung health checks and planning for increased demand for these services. Cancer services will always be a priority for the NHS, and the 10-year plan outlined the continued widening of screening programmes. Our Deputy Director, Charlie Ward, is here to talk about how we support screening programmes, diagnostics and cancer pathways.
Anticipating demand for services is really key for the NHS now more than ever, How does the TU help organisations do this?
So from a demand perspective, we can look at it up two levels. There is, from a strategic perspective, we might be looking at what the population health needs are and how they will change over a period of time. This is particularly useful if you're looking at things like, if you're developing a business case, and what you're trying to do is you're trying to forecast what that future demand will look like, so that if you're doing something like building a new facility or new estates, you're really understanding what capacity you need, and how many beds or how many rooms or how many staff that you might need to service that demand in the future. And then there's a slightly more operational demand modelling that we look at as well, and that might be where you're making a change to a pathway. You might be making a change to a service, you might be introducing a new step in a pathway or even a new test. So you want to really understand what the impact of that will be on that future, on demand for downstream services. So if we look at an example of if we introduce a new screening test, you're going to be identifying more people that need more detailed diagnostics and they might need more treatment. So you're creating more demand downstream. So what we're looking at doing is modelling that.
Okay, so it sounds like we've done a lot of work in relation to diagnostics. If I'm a patient currently receiving a diagnostic or a diagnostic related treatment, how would some of the work done the TU has done affect me?
So from a patient perspective, the work that we do to redesign clinical pathways, to embed new diagnostic tests or new diagnostic pathways, has a really big impact on patients, mostly in terms of how long they have to wait. Firstly, to actually go to that diagnostic service, and then secondly, in terms of how long they have to wait for treatment, should they need it following the diagnostic test. In our work with the community diagnostic centres, much of our effort was focused around increasing capacity. So we were helping organisations to implement new community diagnostic centres, which created huge amounts of capacity that people could access in a much easier way. People could go straight from their GP, straight to diagnostic tests without having to go to elective services beforehand. So that really cuts down that time and increases the availability of appointments for patients. We've done a piece of work recently about redesigning creating a new pathway so that patients can have rapid access to valve assessment. And the reduction in waiting times there as a consequence of that new pathway have been absolutely phenomenal. The patients have gone from, hundreds of days of waiting down to just maybe 20 or so days from when they actually need to be referred by their GP to when they actually have that assessment in clinic.
Thank you for watching this TU Talks episode on our lung health check modelling work. Hopefully today's conversation has given you something valuable to think about, but of course please reach out if you would like to discuss any of these ideas further. You can find us by searching NHS Transformation Unit on LinkedIn or directly via our website.